بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the second part or the second talk of the infra-hyoid neck, and as you remember that we have divided the neck into two parts, the suprahyoid part and the infrahyoid part, and we have further divided the infrahyoid part into two subdivisions. We have dealt with the first division, and now we are talking about the second one, which will deal with imaging of the cervical lymph nodes as well as the thyroid and parathyroid pathology. Then you remember that in the CT scan of the neck, we usually include the area to be scanned, and we align the scanning plane as much as we can perpendicular to the laryngeal ventricle, and we proceed from up down every 2 millimeter scan intervals. We need to inject the contrast media in many times, and the II DRE reconstructed images in the sagittal and the coronal plane are valuable for the diagnosis, and sometimes we may use the bone window if there is a suspicion of bone pathology in the cervical spine or cartilage pathology in the laryngeal cartilages. Considering the MR imaging, we use the dedicated surface coil, and we follow the protocol having T1 and T2 weighted images, and also we may have coronal and sagittal planes. It's important to remember that whenever we are going to inject contrast media, we need to have a fat suppressed images before and after injection of contrast. Also, sometimes we may use the facility of MR angiography to show the flow within the vessels. This is the anatomic divisions of the neck. And you remember the suprahyoid neck, we have dealt with the anatomy and pathology of the tongue and mouth floor. Then we discussed the issue of salivary gland lesions, and the paropharyngeal space is discussed as a separate entity. And infrahyoid neck, we have discussed the cystic lesions of the neck, the vascular pathology, and the laryngeal imaging in the first part of this infrahyoid neck. And now we will deal with the neck lymphadenopathy as well as the thyroid and parathyroid pathology, inshallah. Considering the lymph nodes of the neck, we have many anatomic divisions or groups, but this is a reliable descriptive way to assess the lymph nodes in the neck. We consider the submental group of lymph nodes as the group 1, and group 2 are the lymph nodes located around the submandibular salivary glands. Then we have the upper and lower deep cervical lymph nodes or the internal jugular, which are located deep to the sternomastoid muscle. The landmark between upper and lower groups is the hyoid bone. Then we have the spinal accessory or the posterior group of neck lymph nodes, and finally we have the supraclavicular nodes. You remember that in the past, whenever the CT was the only imaging way, and also the ultrasound to assess the neck lymphadenopathy, we used to use the size of 1.5 centimeter as a threshold for the pathologic nodes. But this was greatly affected the sensitivity of lymph node detection. Then the usual size or the usual threshold used nowadays is 1 centimeter for the size of the pathologic node. Also, they taught us that the normal nodes are usually oval in shape or kidney shape, while the pathologic nodes may be rounded or lobulated, for example. Then you see here a group of lymph nodes in the submental area. This is the submandibular salivary gland on both sides, and you may see some of the nodes deep to the sternomastoid muscle at the level of the hyoid bone, meaning that they are in the upper group lymph nodes. Then we know that the differential diagnosis of nodes lies between inflammatory and the neoplastic, and sometimes you may get lymph node hyperplasia, such as in Kesselman disease, for example. But it's very important to have the clinical findings of the patient, and they help you for the differential diagnosis, and to look carefully in the images, searching for a primary lesion which may lead to metastasis in the visualized groups of lymph nodes. In this case, the asterisks show an enhancing mass, and this mass is a neoplastic lesion affecting the lower lip, and here you can see bilateral necrotic nodes, especially on the right side. They are large, and this is the usual appearance of metastatic nodes. They have a necrotic center and a peripheral enhancing margin. Then an oral cavity carcinoma like this one, which affects the floor of the mouth on the left side, and you can see an ipsilateral node deep to the sternomastoid showing a necrotic center and a peripheral enhancement denoting lymph node metastasis. But in this case of a child 5 years old, she had a mass which is related to the angle of the mandible anterior to the submandibular salivary gland, and the mass has a necrotic center. And what's very important here is to look to the stranding of the subcutaneous fat. And this, in my opinion, is considered one of the pathognomonic signs that you are dealing with an inflammatory lesion, especially whenever it is subcutaneous in location like the parotid gland and the submandibular salivary gland as well. This is an inflammatory node, and you can confirm this by the clinical data, which will show some signs of inflammation at this particular swelling. Then in Egypt, there are many cases of TB affecting different parts of the body, and this is the usual appearance of tuberculous lymph nodes in the neck. And the nodes are small, they are adherent to each other, they have a caseating necrotic center and a peripherally enhancing margin. In the acute phase of TB lymphadenopathy, you may get homogeneous enhancement of the affected nodes. In the subacute phase, you got central areas of breakdown, and after healing or in the chronic phase, you got nodal calcification. Then bilateral tuberculous lymphadenopathy, this is an almost pathognomonic appearance for tuberculous lymph nodes in the neck, as well as anywhere like the mediastinum and mesentery, for example. Then in this case, you see a lesion which is marginally enhanced with central necrotic part, and this lesion is located at the anatomic site of a known lymph node group. Then you should consider it is of lymph node origin, and this was proved to be a biogenic lymphadenitis with an abscess formation in the upper deep cervical lymph node. Then infectious mononucleosis is one also of the viral infections which lead to enlargement of the lymph nodes, and the nodes are usually of homogeneous CT density. They do not contain necrotic center, and in this particular appearance they may simulate the sarcoid nodes or the other viral infection nodes, and the Kesselman disease, which represents the nodal hyperplasia. In patients with AIDS or those who are immune compromised, you may get cervical lymphadenopathy and also enlargement of the lymphoid tissue in the neck, particularly the adenoids. And you get also, you remember, in the parotid gland, multiple lymphoepithelial cysts, which are spreaded in the parotid glands in patients known to have HIV positive. Then the presence of cervical lymph nodes in an AIDS patient may represent the reactive nodes, and maybe the sequelae or an indication of the presence of lymphoma. Usually we used to look at the calcified nodes as if they are post-inflammatory, but you should remember that some of the neoplastic nodes may contain calcium. The most common inflammatory lesions which show nodal calcification are the TB and sarcoid, but pneumoconiosis may show calcified lymph nodes, the amyloid, the scleroderma, other granulomas other than TB and sarcoid, and also the Castleman disease. But neoplastic nodes which may show calcium are those coming from the medullary thyroid carcinoma, which is known to give metastatic nodes containing calcium, and the pulmonary metastasis containing calcium. Also, the prostate and the colon, especially the mucinous adenocarcinoma of the colon, give calcified metastasis. In cases of lymphoma and metastatic nodes after treatment, they may show some calcification, which may indicate a process of healing. Then our policy for assessment of cervical lymph nodes is to look in the clinical findings and to look in the imaging. In the clinical findings, if there is a non-primary malignancy, then you should consider metastasis. If the patient is known to have lymphoma, then you consider lymphoma. If the patient is known to have sarcoid, then you consider sarcoidosis. But in the imaging, if you look in the scans and you see a primary, like nasopharyngeal cancer, laryngeal cancer, then you consider the nodes as deposits. If you see bulky, homogeneously enhanced nodes that are amalgamated, you think of lymphoma. If you see nodal calcification, and you think of the inflammatory lesions, although you know that some of the malignant conditions may show nodal calcification. And if you see nodes with necrotic center, they consider the two possibilities, inflammatory nodes and metastatic nodes. Then, if you do not have any clinical evidence of these or any imaging findings of these, then you will say in your report that I am seeing cervical lymphadenopathy for biopsy. And I think you all know that the best way for evaluation of lymph nodes in the neck is through the fine needle aspiration cytology guided by ultrasound. This is one of the best ways and the quick ways. If you have a good pathologist, then you are able to sample any of the nodes in the neck and send it for cytology. Then you got the immediate diagnosis. And this is just an example of a typical case of sarcoid, where you see bilateral, almost symmetrical enlargement of the hilar lymph nodes. And in the same case, you can see lymph nodes in the neck, and these nodes are homogeneous. They do not contain areas of breakdown. Also, they are discrete and not amalgamated. And these are the descriptive terms of sarcoid lymphadenopathy. And here, the nodes are more bulky. They are also discrete, but they are bulky and they are homogeneously enhanced, no areas of calcification or breakdown, anything of lymphoma. Then in this patient with oral carcinoma, you see this is a metastatic node and this is another nodal metastasis, and this is the normal submandibular salivary gland on both sides. Nodal deposits may have usually have necrotic center like this. In this patient with a non-esophageal cancer, and you see two necrotic lymph nodes in the neck, and this feature, as written here, are uncommon for lymphomatous lymphadenopathy. And this is a common appearance of necrotic nodes that are affected by TB. And you see that the smaller nodes are homogeneously enhanced, and larger nodes may have a necrotic center and a peripherally enhancing margin. And some of the nodes, whenever it's infected, it will form an abscess, and here you see a multilocular abscess in one of the lymph nodes in the upper deep cervical group of lymph nodes. You can appreciate the stranding of the related fat planes and the edematous changes in the wall of the pharynx as well. Then, if you see lymph nodes without imaging criteria suggestive of a specific disease or clinical data leading to a specific diagnosis, then you would say that I am dealing with cervical lymphadenopathy. This is the submental group, submandibular group, upper deep cervical group, then cervical lymphadenopathy for biopsy. And you know that the best way is through ultrasound, fine needle aspiration cytology. Then we came to the thyroid gland, and we will have some of the anatomic details. Then we mentioned something about the congenital ectopic thyroid, then thyroiditis, and we have the biogenic thyroiditis, the Hashimoto and radial thyroiditis, then thyroid cysts and goiter, thyroid cancer, lymphoma, and metastasis. Then you know that the thyroid gland is conical in shape, but the apex is almost at the middle of the thyroid cartilage, and the base is almost at the fifth or the sixth tracheal rings. The measurements of the thyroid gland is 5 cm long, 3 cm width, and 2 cm thick. The blood supply for the superior part is derived from the thyroid artery of the external carotid artery, and the inferior part, the inferior thyroid artery comes from the thyrocervical trunk from the subclavian artery. Then ectopic thyroid or lingual thyroid is the thyroid gland that is present in an abnormal location along the course of the descent of the thyroid gland from the base of the tongue to its original site in the neck. This is the foramen cecum, and this is the course of the thyroglossal duct, and along this duct you may see cyst, which is well-known cyst in the neck known as the thyroglossal duct cyst, and also you see an arrest of the thyroid gland. In this particular example, at the level of the normal anatomic location of the thyroid gland, you don't see any thyroid tissue. But in the base of the floor of the mouth, there is a big lump encroaching on the oral cavity, and this lump shows matrix calcification and is bright or hyperdense in the without contrast enhancement, denoting the thyroid tissue, which is usually hyperdense in the pre-contrast scans. Then these are two different examples for an ectopic thyroid gland or lingual thyroid at the base of the mouth floor encroaching on the oral cavity, and this is the thyroid scan where you see uptake near the floor of the mouth without uptake in the lower part of the neck. This lingual thyroid may be the only functioning thyroid tissue in about 70% of the cases. The same lesions occurring in the thyroid gland can occur in the lingual thyroid, especially this type of papillary carcinoma, which is the most common type of malignancy in the thyroid gland. And this is the appearance of a lingual thyroid, and the CT scan of the same case showing the mass related to the mouth floor encroaching on the oral cavity. Then we came to the inflammatory lesions, and I should say here that most of the thyroid lesions give no specific imaging findings except for the goiter. But we usually use the combination of the clinical data, the imaging finding, and the fine needle aspiration cytology guided by ultrasound to reach the final diagnosis in many of these cases. An acute infection of the thyroid may be the sequelae of a staphylococcal infection or hemolyticus or other types of bacteria, including also sometimes some types of fungi and specific organisms like TB. In some cases, maybe the sequelae of trauma or irradiation, and the imaging findings are usually non-specific. You remember, or you should remember, that the thyroid is normally very resistant to infection. And you know that iodine, which is one of the major disinfectants, is highly concentrated in the thyroid gland. Then the incidence of acute thyroiditis is about 1 per 1,000, and the appearance will be more common in especially in the children due to some of the relation to the pyriform fossa. I will mention it just now. Then this acute suppurative thyroiditis may be common in patients with prior thyroid disease like Hashimoto thyroiditis and even thyroid carcinoma. And in patients, because this gland is resistant to infection, the infection is usually seen in immune compromised patients. And this is an appearance of enlargement of the right thyroid lobe with marginal enhancement and central area of breakdown. This is what we call pyriform sinus fistula, and this was found a common cause of acute thyroiditis in children. There is a fistulous tract between the pyriform sinus and the thyroid site, and this fistula is almost seen on the left side. Then you see a slight enlargement of the thyroid gland, which is relatively hypodense, and you see air loculus within the infected thyroid. So if you see a lesion like this in the thyroid gland, in absence of clinical data, you cannot say that this is acute suppurative thyroiditis. But if you have some clinical data and you examine the patient and you find some signs of inflammation, then you may suspect this, and you put a needle to have an aspiration sample for analysis, and then you will reach the diagnosis. As I have mentioned, many of the thyroid lesions may be superimposed. In this particular example, you see acute suppurative thyroiditis with radial thyroiditis and on top micropapillary carcinoma as well. But all you see in the imaging finding, and you see a lesion which is marginally enhancing with necrotic center and matrix calcification. Then you reach all these diagnoses by the fine needle aspiration cytology. This patient with fever and systemic debilitation, and you see an abscess-like lesion in the right thyroid lobe showing central fluid hypodensity with uniform thickened enhanced margin. The second type of thyroiditis is Hashimoto's thyroiditis, which is an autoimmune disease of unknown etiology, and this is the incidence of the patient of the considering male and female incidence. The clinical findings include thyroid enlargement, and this enlargement may be symmetric or asymmetric, may be lobulated or smooth, and also the patient may gain weight and feel fatigue with sometimes the patient is pale and with buffiness of the face and joint and muscle pain, and the females find some difficulties to get pregnant and irregular menstrual cycle. All these are supportive clinical data, but you are not able to reach the diagnosis without the cytology. In the ultrasound, you see diffuse enlargement of both thyroid lobes, and if you have the Doppler images, you can see some vascularity within the affected gland. And we know that Hashimoto's thyroiditis may show normal vascularity or low vascularity or even hypervascularity. This is not constant for the thyroid gland. But here, this is the pre-contrast scan and this is the post-contrast scan. You see diffuse, almost symmetrical enlargement of the thyroid lobes as well as the isthmus. They show almost homogeneous enhancement with lobulated appearance, and you cannot say that this is Hashimoto's thyroiditis unless you have the pathology. And by ultrasound, there are some of the reported features to help you to suspect the possibility of Hashimoto's thyroiditis, but they are all non-specific, such as diffusely enlarged thyroid gland with heterogeneous ecotexture, the presence of hypoechoic micronodules like these small nodular hypoechoic lesions surrounded by bright or echogenic septations like these echogenic lines. Then as I have mentioned, the Doppler may show the normal flow or decreased flow or maybe sometimes a hypervascularity. With this kind of thyroiditis, you may find some of the reactive cervical lymph nodes that are present. Then this lesion is one of the risk factors for the papillary thyroid carcinoma. Then we came to the riddle thyroiditis, which is an extremely rare or a very rare disease. This disease is more common in females and is characterized by extensive fibrosis of the thyroid tissue. And based on this finding, you will see that the affected thyroid gland is enlarged and it shows diffuse low signal in all pulse sequences by MRI, diffuse in the T1 and the T2 weighted images because of the presence of fibrous tissue. But whenever you inject a contrast medium, it will show some enhancement. Then this gland affected by Riddle's thyroiditis is very firm and hard, swelling in the anterior part of the neck. And in the literature, they say that it's difficult to differentiate between this Riddle's thyroiditis and the thyroid carcinoma or lymphoma. This is the appearance by CT, MRI, T1, T2, and T1 post-contrast. The thyroid gland is of low signal in the T1 and T2 weighted image with some faint homogeneous post-contrast enhancement. And these arrows points to a small part of normal thyroid tissue that is not involved by fibrosis. It is seen here by the CT scan and the T1 and the T2 and after contrast enhancement. This is also an example of Riddle's thyroiditis. You see the thyroid gland is enlarged and you see matrix calcification by CT. You know that MRI is less sensitive for detection of calcium, but the evident hypointensity of the lesion in the T1 and T2 weighted images is usually suggested. Then we came to the thyroid nodules, and we know that most of the nodules are on the benign sector and a small percentage on the malignant sector. The nodules may be hyperplastic or an adenomatous nodule or a cyst. Then we'll discuss first the thyroid cysts, which are common, and in many cases they represent about 20% of the thyroid nodules, and they usually considered to be degeneration, the sequelae of degeneration in adenomatous nodules. Then whenever you have imaging by ultrasound, CT or MRI, and you can see a cyst which is filled with fluid related to the thyroid gland. Then this system usually show hypodense fluid contents unless it bleeds. Then you got a hemorrhage inside the cyst with increased density of the cyst contents. And in every case, you should have to aspirate this cyst by ultrasound guided to ensure that the cyst contains thyroid cells, meaning that it is of thyroid origin, and to exclude the presence of malignant cells. And then this is the appearance of hemorrhagic thyroid cyst. You see a big cystic lesion of relative hyperdensity in the region of the right thyroid lobe, secondary to hemorrhage. And if you see a cyst with a solid component, then you think of malignancy. But here in the thyroid gland, if the solid component is more than 50% of the cyst size, then the risk of malignancy is about 20%. But if the solid component is smaller than that, then the risk of malignancy is about 5%. And this is a benign thyroid cyst. You see a cystic lesion related to the right thyroid lobe with some internal septations and maybe a solid component, but the aspiration cytology showed no evidence of malignant cells. And this is also a big cyst in the right thyroid lobe, and you can see the claw sign, which is similar to the claw sign of the renal cyst. That means that there is extension of the enhancing thyroid tissue along the wall of the cyst, denoting it is of thyroid origin. And aspiration of this cyst revealed brown fluid, meaning that there is some hemorrhage in this cyst, but the cyst usually refill again. And this is the sequelae of aspiration of most of the benign cysts. They usually recur after aspiration. Hydatid cyst can occur also in the thyroid gland. It may show the classic features of hydatid, like the presence of daughter cyst, the presence of floating shadows, or the presence of mural calcification. And this cyst, without any diagnostic features of hydatid, was seen in a patient that has also other cysts in the liver, in the kidney, and in the lung, and also in the anterior abdominal wall. Then the indirect hemagglutination test was positive for echinococcal disease, and this is the follow-up after receiving treatment, showing the decrease in the size with crumbled endocyst within the cyst itself. Then you know that I have mentioned that the thyroid nodules are on the benign sector in 95% of the cases, and on the malignant sector in about 5% of the cases. And if you see a nodule like this in the thyroid lobe, then you would say that they may represent a cyst in the thyroid, or an adenoma, or focal thyroiditis, or even carcinoma. Then you have to verify the nature of this nodule by having a fine needle aspiration cytology guided by ultrasound. And in a single nodule, the incidence of malignancy is about 15%, while the incidence of malignancy in multiple nodules is less. It is in the range of 6%. And this is a nodule in the right thyroid lobe, showing a solid component and the cystic component. And whenever it was biopsied, the histopathology result was clusters of benign follicular cysts and no evidence of malignancy. And you remember from the chest lectures that one of the common superior mediastinal masses is the goiter, or retrosternal extension of the thyroid goiter. Then you know that we may consider that the only lesion which displaces the trachea is of thyroid origin. And there is a lesion here, and it's above the level of the aortic arch. You cannot see the superior margin of the lesion, denoting it is coming from the neck. And this is a retrosternal extension of the thyroid goiter. Goiter is a common pathology seen in about 3 to 5% of the population, commonly seen in females where it was old age. And the affected thyroid will show multiple variable sized nodules, and these nodules are maybe cystic and maybe solid, and they may show internal hemorrhage, and frequently they also show some calcification. And commonly, goiter may affect both thyroid lobes, but it may affect one side more than the other side, and also may extend inside the thorax and may not. And this is a huge multinodular goiter affecting the isthmus, the left and the right thyroid lobes. But the left lobe is markedly enlarged, as you see here, with nodules containing hypodense colloid and also foci of matrix calcification. Huge multinodular goiter affecting both thyroid lobes, markedly compressing the trachea, and this is the endotracheal tube. And this is an example of huge multinodular goiter affecting the left lobe of the thyroid gland more than the right lobe, with areas of hypodensity as well as some of the calcium inside the affected gland. And you see the large intrathoracic retrosternal extension. Then we came to the thyroid cancer, and we have 4 types of thyroid carcinomas: the papillary type, which is the most common; the follicular type, which is less common; the medullary type, which is a little bit rare; and the anaplastic type, which is the rarest. Then we should know that we do not have any specific imaging criteria for the diagnosis of thyroid cancer, and we depend mainly on the aggressiveness of the lesion. You may see a large lesion that is invading the adjacent structures, or it may have metastatic lymph nodes in the neck, or may show some distant metastasis like in the lung or anywhere. And whenever you see a solitary lesion in the thyroid, then you think of, you have to exclude the possibility of malignancy, because the malignancy in a solitary nodule is a little bit higher than in cases of multiple nodules. The papillary carcinoma, this is the incidence, is 3 times more common in females than males, and this is the age incidence in the 3rd and 4th decades of life. It has an excellent prognosis, even in the presence of lymph node metastasis, reaching about 90% for 20-year survival rate. And here you see that there is a mass in the right thyroid lobe with metastatic node in the lower deep cervical region. And you should know that metastatic nodes occur in about 50% of the cases, and the prognosis is not affected by the nodal deposits. Also, one of the manifestations of papillary carcinoma is to metastasize to the lung. And we used to know that miliary metastasis, one of the famous causes of miliary metastasis in the chest, is the presence of papillary carcinoma of the thyroid. And this is bilateral papillary carcinoma of the thyroid gland with miliary metastatic deposits in the lung bilaterally. You know that the role of PET scan is not well established in the diagnosis of thyroid cancer. It will show a strong uptake with increase in the standard uptake value, denoting the presence of malignant lesion. But you all know that PET scan may show increased uptake in inflammatory lesions as well. So the final diagnosis will be reached through the biopsy, which is commonly guided by ultrasound. And this is an example of papillary thyroid cancer by CT without contrast, and the PET scan showing very much increased uptake inside the lesion. This is a case of MRI T1 weighted image and T2 weighted image showing a papillary thyroid carcinoma in a thyroid cyst, and you see the solid component is large. It was biopsied and proved to be a papillary thyroid carcinoma. And this patient in particular have a papillary thyroid carcinoma of the left thyroid lobe that has been removed. Then he developed a papillary carcinoma in the right lobe. And follicular carcinoma is one of the lesions that is more or less quiescent. And you see a focal lesion in the thyroid gland. It's common in the females than in males, usually seen in the 5th decade of life. And this follicular carcinoma usually do not have lymph node metastasis. Metastatic lymphadenopathy is uncommon, and also hematogenous deposits are uncommon. Then you see a lesion that is well located in the right thyroid lobe, and you will reach the diagnosis of follicular carcinoma, of course, by biopsy. The role of PET scan is to show if there are metastatic lesions, for example, in thyroid malignancies. But if you see an increased uptake like this, this will not support the possibility of malignancy, since you may see this uptake in inflammatory lesions as well. Then the medullary thyroid carcinoma is the lesion which produce calcium, and the calcium will be seen in the metastatic nodes as well as in the metastatic deposits like here in the liver. So we do not consider the calcified nodes as of inflammatory origin, but we should remember that some of the calcified nodes may belong to malignancy. The last type, which is the less common type, 2% of the thyroid malignancies, is the anaplastic one, which is the most aggressive. And this lesion may show calcium, and frequently it shows invasion of the surrounding structures and also lymph node metastasis. And you see here a huge mass on the left side that has infiltrated the larynx and the pharynx. And this is one of the attitudes of the anaplastic thyroid carcinoma, huge mass affecting the left thyroid lobe, and you see the marked shift and displacement of the trachea and pharynx. This is also another example by MRIT, one-weighted image after contrast injection with fat suppression. You see a large tumor mass in the left thyroid lobe. Then the medullary thyroid carcinoma is a component of the multiple endocrine neoplasia syndrome type 1, type 2A and type 2B. In type 2A, you may see medullary carcinoma of the thyroid, pheochromocytoma, and parathyroid adenoma. The medullary carcinoma is also one constituent of main type 2B with mucosal neuromas and marfanoid fascias. This multiple endocrine neoplasia syndrome is an autosomal dominant disease, usually seen in younger patients, and is bilateral in most of the cases. Then lymphoma is one of the lesions that can occur in the thyroid gland. It represents about 5% of the thyroid malignancies and is usually a primary lymphoma. It may occur on top of Hashimoto thyroiditis, as I have mentioned. Then the imaging findings are once more non-specific. You see mass affecting both thyroid lobes, and the affection may be symmetric or asymmetric. The enhancement is usually homogeneous with no areas of breakdown or calcification. Then if you use the PET scan, you will see severe uptake in the malignant mass. One of the supportive features is the presence of bulky cervical lymph nodes in the neck together with the thyroid mass, which supports the diagnosis of lymphoma. Then the presence of solitary or multiple masses in the thyroid gland, and the presence of bulky extraglandular invasion and regional lymphadenopathy may be helpful, but the final diagnosis is through the biopsy, the needle biopsy. In the previous days, and it may be still used up till now, which is the gallium scan. Gallium is specifically taken by lymphoma tissue, and it may help to discriminate between lymphoma and carcinoma, but as you know that it is much more easy to have a biopsy and to have a solid evidence of a histopathologic diagnosis than to do the gallium scan or the PET scan, for example. Then metastatic deposits may affect the thyroid gland, and they represent about 2% of thyroid malignancies. And of course, the imaging findings are not diagnostic, but you need the clinical data of a known primary malignancy. And this is a case of renal cell carcinoma metastasizing to the thyroid gland with a large mass invading the surroundings, as well as some of the metastatic nodes as well. Then this patient had a pancreatic adenocarcinoma with a large cystic or partly cystic metastatic deposit in the right thyroid lobe. This is the normal left thyroid lobe. In this case, the patient had a gastric adenocarcinoma that has a metastatic deposit in the right thyroid lobe. Finally, we came to the issue of the parathyroid glands, and you know that there are normally two pairs of the parathyroid glands related to the posterior aspect of the thyroid. The upper parathyroid glands are located posterior to the middle part of the thyroid gland. The lower parathyroid glands are usually located inferior to the lower thyroid ball or posterior to it. And you may know that up to 12 parathyroid glands may be present in a single subject. The normal measurements of the parathyroid gland are 6 by 4 by 2 millimeter, and it weighs about 40 to 60 milligrams. Then the parathyroid glands are considered endocrine glands, and they produce the parathormone, which controls the calcium metabolism. Then about 3 to 6% of the people may have less than 4 parathyroid glands, and about 6 to 12% of cases may have more than 4 parathyroid glands. This is the common location of the parathyroids, but ectopic parathyroid glands can occur in about 15 to 20% of the cases in the region between the carotid bifurcation and to the anterior mediastinum. Then the clinical presentation of patients with parathyroid adenoma include, of course, the presence of hyperparathyroidism, and this may result in osteoporosis, multiple renal stones, constipation, peptic ulceration, and the remaining features of hyperparathyroidism. Then the imaging findings of parathyroid adenoma as seen by ultrasound. Then you see a single, it's usually single, but maybe multiple, a single lesion which is relatively hypoechoic compared to the echogenicity of the adjacent thyroid tissue. This is the diagram showing the possible ectopic sites of the parathyroid glands. And you see up to the carotid bifurcation and in the superior mediastinum as well. Then parathyroid adenoma may degenerate to form a parathyroid cyst, which is not commonly seen in the clinical practice. The hyperparathyroidism, the incidence is about 1 to 2 per 1,000, and it is more common in females compared to males. The most common cause to produce or to result in hyperparathyroidism is the parathyroid adenoma, and also parathyroid hyperplasia, multiple adenomas in about 2% of the cases, and carcinoma, which is extremely rare in 1% of the cases. The parathyroid adenoma, its size is up to 1.5 centimeter in diameter. This is the commonly seen size, but the size may be larger than this and may reach a few centimeters. Then in the previous days, we used not to look for the parathyroid adenoma, just we diagnose the patient to have hyperparathyroidism, then they explore his neck looking for the parathyroid adenoma. But nowadays we may go for imaging, especially in these particular situations. Number one, in recurrent cases. Number two, to have unilateral surgical exploration instead of exploring the both sides of the neck, detection of ectopic adenoma before surgery, and detection of other lesions. Then 50% of the patient may have thyroid disease together with parathyroid disease, and of course to decrease the surgical time and the complication. This is the usual appearance of the parathyroid adenoma by ultrasound, and the ultrasound is the initial way for imaging of the neck and to have sampling, to have samples from neck pathologists. Then adenomas more than 1 centimeter can be confidently seen by ultrasound. but the smaller size is of course difficult to be detected. The usual appearance is an oval-shaped structure that is relatively hypoechoic compared to the adjacent thyroid tissue, and if you have the Doppler scan, you see peripheral hypervascularity around the adenoma. And one of the commonly used techniques for detection of parathyroid adenoma and to locate if it is ectopic or not is the nuclear medicine by using the technetium-99m system maybe for the thyroid and the parathyroid glands as well. Scanning after 10 minutes to 15 minutes after injection of the tracer is usually directed to visualization of the thyroid gland, but the delayed scan, which is obtained between 1.5 to 3 hours after injection of the isotope, is directed for the parathyroid adenoma. Then you will see clearance of the isotope from the thyroid gland and persistence of the isotope in the parathyroid adenoma. This is the system EB scan, and you see the thyroid glands, and the delayed one showed the presence of parathyroid adenoma. Then this is one of the important issues to remember, that is a negative system EB scan does not exclude a parathyroid disease, because if the adenoma is small or if there is hyperplasia, you may fail to detect this adenoma. And one of the imaging tools nowadays is what is known as 4D computed tomography, and this is obtained by scanning the neck before injection of contrast material. Then we inject the contrast and have an arterial phase images, and then we obtain the washout phase, or what is known as delayed phase scans. And this is an example. In the pre-contrast scans, you may see some shadow which is posterior to the left thyroid lobe. After injection of contrast in the arterial phase, it shows intense enhancement, and in the delayed phase, it shows washout. These findings are considered by the literature as pathognomonic for parathyroid adenoma in the presence of positive clinical data. Then parathyroid adenoma, if it is relatively sizable in the range of 1 centimeter or more, it can be detected easily by MRI, especially in the T2 weighted image. And you see here a bright lesion which is located posterior to the left thyroid lobe. In the T1, the lesion is of intermediate signal, and in the T2 it will show high signal. But in cases of hemorrhage, you will see high signal in the T1 and also high signal in the T2 weighted image. And if you inject the contrast, it will not result in increase the detection rate of the parathyroid adenoma. This is what we call the technetium-99m system EB SPECT scan, which is the single photon emission computed tomography. This was a way to have anatomic details together with the isotope scan. Then you see an increased uptake here, which is located in the parathyroid adenoma along the inferior ball of the left thyroid lobe. And this is an example of a patient with hyperparathyroidism and a sizable parathyroid adenoma, which is located in the mediastinum. And the CT scan of the same case showed a mass in the right paratracheal area, and the delayed system EB scan showed persistence of the isotope within the parathyroid adenoma. And this is the scan system EB with SPECT CT, and see the increased uptake in the ectopic parathyroid adenoma in the superior mediastinum. And if you see this appearance by CT, and this is by PET scan, and you cannot see significant uptake in this lesion, which is related to the posterior aspect of the thyroid lobe. This may represent a thyroid lesion and may represent a parathyroid lesion. Then you should go for biopsy to confirm the diagnosis, and this was a parathyroid adenoma. Then parathyroid cancer is extremely rare. The incidence is a half per million, and the presence of parathyroid cancer will markedly elevate the level of the serum calcium, and also will markedly elevate the serum parathyroid hormone level. And the presence of these elevations may suspect that the lesion in the parathyroid gland may represent a carcinoma, and this will need to have a sample by ultrasound or any way to have a sample to confirm the diagnosis. Then parathyroid carcinoma is extremely rare, and it has a good incidence of local tumor recurrence reaching about 30%, and distant metastasis in about 30% of the cases. This is treated by radical surgery followed by irradiation, and because of the high incidence of recurrence, there should be a long life follow-up of this particular tumor. The suggestive diagnostic criteria is presence of a neck mass, which is the lesion and nodes or both, and may result in vocal cord paralysis, the presence of marked hypercalcemia, and marked elevation of the parathyroid hormone level. Thank you very much. Alhamdulillah Rabbil Alameen.